Good morning, everyone. So, my name is Valerie Guild, and I'm the founder of AIM at Melanoma, and I want to thank all of you for coming this morning. We have obviously a wonderful turnout. I want to thank the Emory Cancer Institute for co-sponsoring this with us, and I certainly want to thank the presenters, Doctors Lawson, Delman, Washington, and Chen, for coming out this morning. So I want to tell you just a very little bit about AIM at Melanoma. We're an international melanoma foundation. I started this foundation 7 years ago after my daughter Charlie died of melanoma at the age of 26. We have two goals, one of which is to move research forward. I think we're all looking for a cure, treatments. The landscape looks much better. We run an international melanoma think tank. We're looking to create the first melanoma tissue bank. But I will say that just as important is the job of educating patients and their families so that people can make better informed decisions. So if you take a look at your folder, so we'll combine a little housekeeping, you will see a brochure for AIM at Melanoma. We run the most comprehensive melanoma website, the greatest trafficked melanoma website. We're going to launch in Europe, but it truly has a wealth of information about melanoma. I should say that Dr. Delman wrote the sentinel lymph node section for us. And starting next month, we are going to have 30 renowned melanoma specialists, including Dr. Lawson and Dr. Delman, do a blog 3 times a week to keep you informed of what's happening in the world of melanoma in terms of new treatments and breaking news. And you can find those on the website. You can go to our Facebook page. We're going to tape this session, and then we're going to send out an email to you telling you what the link is, so you'll be able to go back and go through these sessions again. You'll also find a pad for notes. You'll find index cards, and if you could use them to jot down any questions you might have for the question and answer session, we'll pick them up right before the break. The agenda is there, and there is a symposium evaluation, and we'd really love you to fill that out and drop it off at the desk. We do these patient symposiums at noted institutions throughout the U.S., and we'll be doing them in Europe next year, and we really do like to get the feedback. So without further ado, I would like to introduce Dr. Lawson.
First of all, thanks to Valerie for putting all this together. We really appreciate it. Actually, I'm just going to introduce Dr. Delman, who's our next speaker. But mostly thanks to you all for coming out. And we think about it, those of us on the panel, at any rate, have never fought melanoma in the way that you guys fight melanoma. And we appreciate what you all do and what you go through and all your hopes and aspirations. And we hope somehow today we can give you some insight into what's going on. That said, I want to introduce Dr. Delman, who's going to start out by talking to us about surgery in melanoma. Dr. Delman comes to us by way of places like New York, MD Anderson, but as they say in the South, he wasn't born here, but he got here as fast as he could. And so, glad to have you.
Wasn't born here, but lucky to be here. I would like to extend my thanks to Valerie and her daughter Samantha and Mary Turner, who all helped coordinate this, Vince Dollard and Teresa Huffman, and the other speakers you're going to hear today. We all really appreciate all the effort they put into coordinating this and getting this together. But I also would like to extend my thanks to each and every one of you. There are a lot of people here that I know personally. There are certainly people here that I know by name. And a lot of this is done not for you, but because of you. And we can't say some of the things we say without your participation in trials and your willingness to share your information and your stories. And you should look around the room and realize that a lot of what we've accomplished in the past several years across the country is because of people just like yourselves around the country. You should be very proud of that also. This morning, my task, not surprisingly, is to talk about surgery and the management of melanoma. But I think that because surgery is often the doorway into your melanoma care, that I'd like to start off with really what happens with you when you get that diagnosis. And when you're going to hear later on some of the details of things, some much more fancy and advanced things that we've accomplished in melanoma. Today, this morning, I'd like to focus on the basics. And so we're going to start off with a few disclosures. It's one of my requirements. I don't get paid by anyone for anything, and even when I'm supposed to get paid. So just so you know. So we can start off there. And then, you know, I also like to say that if there are things that come up along the way, large part of this, Randy Pash, many of you may know, wrote the last lecture, which is a moving book about someone struggling with cancer themselves. And he said, never underestimate the importance of having fun, and I think that's critical. I think that's critical to your whole life, but also to something like this. It's hard to have a lecture. It puts people to sleep and that sort of thing. So we'll try to keep it a little bit engaged. I do have a lot of pictures. I do something like this for middle school students, and I know that pictures keep them involved, so maybe they'll keep you involved also. And so we'll try to focus on that a little bit. So like I said, this morning we're going to talk a little bit about the melanoma basics, what happens in the early phases of treatment, and then specifically focus on what I know, which is the surgical management of melanoma, and then I'll try and get it all together for you with what you should take home from this morning. So by way of background, and I may be repeating some of what others are going to talk about, but there's about 1 million new skin cancers a year in the country. It's the most common cancer. You don't think of it that way because we don't talk about it that much because most of them aren't really collected in cancer registries. They're often treated by dermatologists. And you'll hear from a few dermatologists later today. But those skin cancers include basal cell carcinoma, squamous cell carcinoma, these cancers of the skin, other parts of the skin like sweat glands and little neural tumors in the skin. And then, of course, there's melanoma. Basal and squamous cell cancers account for about 95% of all skin cancers. And even if you've had melanoma, you need to know about basal cells and squamous cells also because they're usually related to one another, and sun damage often causes all of them. But melanoma, despite being one of the rarer of the three most common, still accounts for 97% of skin cancer death. About 70,000 patients this year in the country will be diagnosed with melanoma, and nearly 9,000 will die of the disease. And many of you may realize it's received a lot of popular attention. It's been in the New York Times, it's been on a number of fashion magazines, it's been on TV, it's been on Time magazine, and you have to ask yourself, why, if it's not that common, why does it get such attention? And to all of you, it may be the most important thing in the world, and certainly one of the most important things to all of us. But why does the entire country focus on it if it's not as common as, let's say, the 200,000 people that get breast cancer or prostate cancer? So part of it may be this guy. We all know that he ran for president, you know, and his medical history became a focus of attention for a while because he's had a battle with melanoma, still winning that battle, but he certainly brought it to the forefront for a few years. And so that's part of it, but it's actually more complicated than that. Melanoma is one of the most rapidly increasing cancers that we have to deal with as oncologists. There's a 650% increase in the incidence of melanoma over the past 50 years. That's an enormous number. There's a 185% increase in melanoma-associated deaths. The greatest increase is in women ages 25 to 39. Some of it's related to this. People, the middle school students often ask me why. I think everybody wants to know why, and it's hard to give a definitive answer on that, but a lot of it has to do with cultural change. In the early 1900s, it was actually in vogue to be the porcelain skin, where you see women carrying parasols and that sort of thing, and we don't have that culture anymore. Now it's a culture of being outside and being in the sun. And then, of course, there's the question of the ozone layer, but there's a lot of this. Right? There's a lot of habits to go and start looking for that tan or changing the color of your skin to meet what's considered a societal norm. And we have to fight that battle. Right? In 2003, the CDC reported that only 1 in 7 high school students use sunscreen. We have some high school students in the audience, at least. Well, no longer high school students, but we have a few in my practice, and some have gotten older now. I suppose they all get older. That's good. But recently, the WHO, the World Health Organization, said that ultraviolet exposure is a level 1 carcinogen. That's on par with radiation exposure, asbestos, smoking. Ultraviolet exposure is a level 1 carcinogen now, and that got a lot of attention also. And the thing that's really most stark, and many of you know this, and this is changing, but there's still minimal effective therapy for advanced disease. It's a disease that's highly treatable when found early, but surgery is the mainstay of therapy for most stages of disease. And when we get to the advanced stages, you'll hear a lot about that from Dr. Lawson. But when you hear about the advanced stages of disease and you hear about the progress we've made over the past few years, you still have to recognize that we haven't made the inroads we'd like to make. And that's what all the efforts from the AIM Melanoma Foundation, from all the research efforts that are being made, is towards trying to make that next step. So a large number of you have heard this phrase. In fact, most of you probably had a loved one who has had this happen. And when you get that diagnosis, it's often, unfortunately, on a Friday afternoon. And you have no one to call, and you have no one to ask what it means. And you don't have a chance when you're on the phone and you get that call to actually sit down and think about it and digest it and get your questions answered. So it leaves you a long time to think about it. And leaves you time to stew and boil and possibly go to the internet, and that can be a disaster, as we all know. You have to focus on very, very reliable websites. I'll mention a couple later. And it usually comes from your dermatologist, who then often will refer you, if need to be, to a surgical oncologist, occasionally a general or a plastic surgeon, depends. And then you go on to surgical therapy, and we're going to talk about this in a little bit more detail, all these points, but particularly few, if any, patients, and this is important, few, if any, patients actually need what's called staging. So people come to me and ask, do I need a PET scan, do I need a CAT scan, do I need blood tests? And I'm going to talk about this in a little bit more detail, but let me reassure you when I say to you that you really don't. When you get first diagnosed with melanoma, most patients do not benefit from any type of scanning. In fact, most patients who are being followed for melanoma don't require any routine scanning. But interestingly, despite the fact that there's not much required, only 50% of patients in this country actually get the care that they need. And so education is important. Taking your own initiative is critical. And understanding what you need is important so that you know when you're going forward that you're meeting the benchmarks. And one of the ways to do that, I'll mention in a few minutes, is to make sure that you know your surgeon and you know the people who are caring for you. Surgery basically includes definitive treatment of the melanoma, a wide local excision, I'll talk about this a little bit more, and most often, an evaluation of the lymph nodes. In most patients, nothing more is required. Follow-up, surveillance, physical examination and history, self-awareness, yes, but usually nothing more than just that type of intervention. So as I mentioned, the best thing you can do for yourself is know your surgeon. Check their experience. Hopefully they'll be affiliated with a cancer center, okay? Hopefully they'll have a practice in surgical oncology or melanoma. It doesn't mean they can't be a general surgeon or a plastic surgeon, but they should have experience in treating the disease. You wouldn't go to a mechanic who doesn't know anything about your car. Right? And so the same thing is true of your surgeon. Right? Ask friends, ask relatives. Your personal physician, if you have one, might be a good source. A family member or friend in the healthcare system would be somebody to get reliable information from. And then check reliable websites. And I say reliable, and I underline that because there's a lot of information on the internet. Much of it is just put in by people who want to say something. And you don't know the reliability of that. And the places that have information about your surgeons are the Society of Surgical Oncology, the website's there. The American College of Surgeons has a good reference database. And of course, Valerie's website also has a very good reference point for clinicians in different states. And George is listed on the aim@melanoma.org website also. What happens? Well, at the very least, your dermatologist and certainly your surgeon should do a head-to-toe skin survey, meaning you should get examined from head to toe for anything else on your body. And that should also include an examination of your lymph node basins. If that doesn't happen the first time you're there, it should be because you decided you didn't want it, or for some other reason that is explained to you at that time. But if they don't think about that, that's something that you should at least question when your first encounter, because that evaluation is critical. Now, it may not be obvious to you that the exam is done. Sometimes people are very, very facile at it, but it should be done. because whenever you get diagnosed with skin cancer, the single greatest risk factor for developing another skin cancer is a personal history of skin cancer. Not necessarily other cancers, but skin cancers, right? So the same thing is true if you have breast cancer. The single greatest risk factor for developing breast cancer is a personal history of breast cancer. And your diagnosis ideally would be made by complete depth excisional biopsy. That means a punch biopsy or a narrow margin excisional biopsy, or if you have a large lesion, sometimes dermatologists or surgeons will punch out a focus of disease. Now there's some controversy about the role of what's called a deep shave biopsy, and that can be used as well. I'm not going to get into the arguments about plus or minuses about shave biopsy, but there are other techniques. The problem often is that many lesions when you first present to your dermatologist are not thought to be melanomas because they don't necessarily have the characteristics, which I'll show you in a few minutes, that are the classic characteristics of melanoma. But nonetheless, the biopsy should be obtained. If there's something suspicious on your body, and no one knows your body better than you do, then it's reasonable to do a biopsy. It may not necessarily be needed if your dermatologist or your surgeon tell you that it's got reassuring features. But it's something that if you think there's something concerning, you should bring it to their attention to look at. Right? And these are what primary lesions look like. This is the classic findings. And I don't know whether Dr. Chen or Dr. Washington will talk about this, but there's another thing that you look for, and that's that if you have a bunch of moles on your body and they all look the same, and then one of the things looks different, I think Dr. Chen calls it the ugly duckling theory, but if one of them looks different, or more importantly, the thing that gets me to biopsy more patients than anything else is if you tell me it looks exactly like your previous melanoma, those are things you need to identify. But these are the classic things. We use an alphabet to guide us, A, B, C, D. You can see asymmetry, border, color, and diameter, A, B, C, D. And you can see that there's a remarkable difference between this and this, and this, and this. And what we talk about are the characteristics here. And this comes right off the NCI website, the National Cancer Institute website. This is a very popular table, and you can find it on most cancer websites or some example of it. And that's actually the kinds of things you look for. But it doesn't mean that these are the only things that are suspicious. One of the most important things, because as I said to you, you know your body, is something that's changing rapidly, or growing rapidly, or bleeding, or itching. Those are things that should prompt you to get attention. This is also melanoma, a little different presentation. This is also melanoma. This is melanoma. This is melanoma. This is melanoma. Right? So melanoma takes on many, many appearances. Right? And it's a challenge because those are all different appearances. And not all of them look exactly like those pictures I showed you that are on the website. But they all are melanoma. And what you don't want to do is fall into the trap of thinking that everything looks like that table I showed you, because it doesn't always. So how do we treat you? So now you've been diagnosed with melanoma, and then what happens next? Well, the definitive treatment, as I said, has to address the melanoma itself and usually the nodal base. And the definitive treatment for the melanoma itself is characterized or described by the Breslow thickness or depth. All right? Melanoma, the amount of melanoma that's present when we find it, offers a prognosis. The problem with prognosis is that it's statistics. And statistics are useful to give you a benchmark. But if you're not in that statistical group, then it means nothing to you. And so you need to remember that if it's 95% of people will be fine, and you're in the 5% of people, you don't really care about those other 95% of people. Right? And that's important. It just offers you a guide. And so it's not worthwhile to go on a website and look and see that 50% of people have this come back and 50% of people don't, because that just tells you you don't know what group you're in. Right? And you can't use that as a detractor for your care. But local control, which is what we call that when we do surgery in that area. And then we need to at least discuss the lymph nodes. There are patients who won't need lymph node biopsies, who don't have a risk factor, a risk high enough to warrant putting you to sleep and removing lymph nodes. We'll talk about that in a second. And it may require a survey for distant disease, meaning one of those scans we talked about a few minutes ago, and or a referral to someone like Dr. Lawson or another medical oncologist for what we call systemic therapy, which is what people think of as chemotherapy, but for melanoma it's often not traditional chemotherapy. As many of you may know, it's often immune-based therapy, vaccines, and things like that. And we have patients in the room that have gotten those types of things. But I want to focus on this for a second because this is a hanging point for me. It's not uncommon for patients to come into my office and either have had a PET scan or think that they have to have one because they've read it somewhere in the newspaper or online. And it gives people a misleading sense of security to get a PET scan or a CAT scan, and often leads us down a path of expensive interventions which lead to nothing more than an irritating series of visits to the hospital for a prolonged period of time that leads to just the reassurance of what we thought at the first point, which is that there's nothing there. Right? We know this. If we're going to poke, prod, scan, or test you, that if it's early in the stage of melanoma and you have no symptoms, they really offer no benefit. So who needs to be poked, prodded, blood drawn, or anything like that if it's not going to help you at all? And what that means is not that we can't find things with a radiology test, because we can. But the most sensitive test that we have is a PET scan, and that needs a 7mm lesion. It needs something that's 7 millimeters in size. And think about this for a second for those of you that have had melanoma. Most of you, your original melanoma was less than 7 millimeters in size. So when you walked in the door, even if your melanoma was intact, the PET scan wouldn't have found it. Right? So you need to have progressed well beyond that for the PET scan to find it. So it doesn't mean that the PET scan or the CT scan or a blood test can't find certain abnormalities in your body. The problem is that 60% of patients, as much as 60% of patients who have a PET scan or a CT scan actually have a false positive and go down a route of biopsy or repeat tests or something, or we delay their care to investigate something that's not really significant. And so before you go and say to your doctor, I really want a PET scan, it's important to have the dialogue with whomever's caring for you about what the benefits or risks or utility of that test is. Right? And to confirm this, Ken Tanabe and the group at Mass General just published this week in the Annals of Surgical Oncology, which is one of the journals for people who care for melanoma, that even in patients with swollen lymph nodes from melanoma involving their lymph nodes, only 5% of those patients had some sort of x-ray or otherwise that found another site of disease that changed the management of that patient. And so I reassure you that if your doctor says to you you don't need a scan, that is probably true. There are settings where you should have a scan, and I don't mean to say that you never should have a scan, but I want to reassure you that scans are not the answer to everything. And in fact, we know that most patients actually are more sensitive than their scans. And in fact, in several large studies, it's been shown that even when you're being followed by a trained dermatologist or a surgical oncologist or a medical oncologist, that patients or their significant others are more accurate at identifying their recurrences or new lesions than anyone else. 85% of recurrences are detected by the patient or their significant other. 85%. Even when you're being followed by a trained caregiver who knows what melanoma is. And why is that? Well, because for one thing, you see yourself more regularly, and two, you know yourself better than anybody. And the hardest thing to deal with is a little bit of denial that comes with you know something's wrong and you don't want to address it because you don't want to know what comes with that. But you know. And so the NCCN, which is the National Comprehensive Cancer Network, is a collection of cancer centers around the country that get together and offer a consensus on the management of patients. And if you have stage 1 melanoma, they recommend that you have a physical examination and just a history. Just check in with your doctor on a regular basis. And then if you have stage 2, they recommend a physical examination or history. And this is outside of a clinical trial. So if you're in a clinical trial, that'll differ, obviously. And if you have stage 3, which is disease in your lymph nodes or multiple spots on your skin within a given range between your primary melanoma and your lymph nodes, you get a physical examination history and symptom-driven imaging, meaning you come in and you have a new cough out of nowhere, or you have a severe headache, or you have bleeding or something that doesn't make any sense, or you have symptoms otherwise that you can't explain, that gets a scan. And for stage 4, even for stage 4, the imaging is guided by the clinician's judgment. That patient should have imaging, but how much, how frequently, what type, that's up to the doctor taking care of you and you to determine what's best for you. And it differs from patient to patient. This is truly individualized care. The most important part of surveillance, though, is at the top of the screen, and that's that self-examination monthly. Once a month, not more, because if you do it too frequently, you'll start to miss things. But once a month, you should do a self-skin examination. The same thing is true of women with the self-breast examination and men with the testicular examination. These should be done once a month. They're routine things you can do. You can save your own life. pretty powerful tool. And so going back to what happens when you get to the surgeon, we talked about this a little bit, but it's a wide local excision, and it's often a sentinel lymph node biopsy, and we're going to get into some details of surgery now. So you get the call on Friday, and the first thing you want to do is panic, and I understand that. And I think that that is something that happens, and that's unfair for you. You have to sit through a weekend, often a week or two before you see the surgeon. And I want you to understand that we do have data that you can wait as long as 6 weeks and probably longer. We've only looked at that long because that was about the average time we transitioned to referral to actually being seen by the surgeon at Anderson. And we looked at that, and it doesn't have an impact on your outcome. While cancers grow, we think of as fast, fast is a relative term. If you think about your body and how it grows over years, cancers grow faster than your body, but not in a matter of days and weeks when they've already been mostly removed, which is what usually happens at your biopsy. So be reassured by that, and I'm not saying that we should put it off, but I'm saying that if you have things that are interfering with your ability to come in, you have a little bit of latitude. All right? Most patients who get referred in have survival rates greater than 90%. Now that may not be true of the medical oncologists per se, but by the time you get to your first visit, usually most patients have survival rates over 90%. That's stage 1 and early stage 2, right? And I want to stress something that's really critical, because you'll often get called by a dermatologist in the community's office, by a receptionist or a nurse who may not have all the information and reads you something off and it often will misrepresent Clark's level, which has the same Roman numeral characterization as stages. And I would say, and this is an estimate, about 65 to 70% of my patients walk in my office thinking that they have stage 4 melanoma, which most of you know is metastatic melanoma and has a very dismal prognosis for many people. But again, statistics make that all interesting, right? But Clark's level 4 is not stage 4 melanoma. In fact, Clark's level 4 is often stage 1 melanoma, which has a 95 to 98% cure rate, right? Not stage 4 melanoma. Wide excision usually has about a 4 to 7 inch scar. We take at least a centimeter of normal skin around the diameter of the melanoma, sometimes a 2 centimeter diameter of normal skin. Sometimes we do special techniques, which you may hear about later, which particularly in areas around the eyes and things like that, around the lips. But in general, it usually involves a 4 to 7 inch scar. It's removal of the melanoma in an area of normal skin, and then we close the wound, hopefully. And we either do that with primary closure or a skin graft, and I'll show you a picture of that later on. But the most complicating thing about melanoma is probably how you manage the lymph nodes. What do you do about your lymph nodes? Because melanoma likes to go to the lymph nodes. Compared to other cancers, melanoma definitely likes to go there. And the lymph node status, we know, is the strongest predictor of outcome after you take into consideration the melanoma itself. And prior to the advent of the sentinel node biopsy, which is the fancy thing we now do, staging in the lymph node basin wasn't done. We just took out all the lymph nodes for most patients. 85% of people didn't need that. We were doing unnecessary surgery in 85% of people. But the sentinel node biopsy also allows us to identify that first lymph node and look at it very carefully. Okay, so you look at that first lymph node that collects cells from the site of the melanoma, and you look at it in fine detail. Right? It has 3 parts to it. It has a map. So you go in the morning of surgery, you get an injection, you get a series of pictures taken to find the lymph nodes that are associated with that area of skin. And then you do the lymph node biopsy, and that removes somewhere between 1 and 5 lymph nodes. You have thousands of lymph nodes in your body. In any one given region, you have somewhere between 10 and 40. And we remove on average between 1 and 5. The real average is 2. And then that lymph node comes out of your body, and we give it to a pathologist, and they take and they slice it up very carefully and look for even a single cell of melanoma. It's a very accurate test. There's nothing more accurate that we do from an imaging or testing standpoint for disease. Right? The thing about it is it's got very little complications. So we offer it a lot more readily than we necessarily would need to, because it's pretty low risk. It only has about a 5% complication risk to it, compared to 20 to 50% of taking out all the lymph nodes. Right? And the complications are relatively minor. They're relatively short-lived. They include something called a seroma, which is when you get a little bulge there. Many of you who I've operated on have had that. You can get a wound infection. Of course, anytime we do an operation, you get a wound infection. But lymphedema for a sentinel node biopsy has actually almost never been reported. It's less than 1%. If you have a big part of your limb removed because you have your melanoma on your limb, your arm, or your leg, patients often get swelling from that, but it's rarely just from the sentinel node biopsy itself. And it is critical because it gives you a more accurate inspection of that specific lymph node than taking out all the lymph nodes, just giving a pile to the pathologist to look at. It's a tremendous revolution. It's a credit to Don Morton and the group at UCS, at John Wayne Cancer Institute in Los Angeles, who actually developed the technique and modified it to melanoma. Right? So the thing you need to know is most people get sentinel node biopsies, but who doesn't need a sentinel node biopsy? It's easier to tell you who doesn't get one than to go through everybody who should get one. And I think it's important you recognize, going back to statistics, that there's no absolutes. It's not as though as if you suddenly go from 0.5 millimeters to 0.6 millimeters that you are going to have a sentinel node biopsy. That's not the way it works. There are a lot of factors that play into it. But for a rough thumbnail sketch, most people who have lesions greater than a millimeter in depth will have the procedure done unless you already know you have melanoma in your lymph nodes. You're too ill with other medical problems to tolerate an operation. You decide you don't want it. You certainly don't have to. We won't hold you down. Or you have melanoma in other parts of your body. You have metastatic melanoma. In those patients, we will consider not doing it. Sometimes we do consider doing it if it will help us manage your disease better to know. In patients under a millimeter in depth, most people don't need one. But the people who really don't need one are those that don't have any high-risk features. And I'm not going to go into the details of what high risk are, but you should have that dialogue with your surgeon. Most patients under a millimeter in depth don't need one. But there are definitely indications for people who have thin melanomas, which are what those are called, that do need one. And there are things like ulceration and things under the microscope that your surgeon should discuss with you. So now, what happens when you get the next bit of information back? You have your wide excision, you have your sentinel node biopsy, and you sit down with your surgeon, hopefully face to face, and he or she says to you, you do have melanoma in your lymph node. Well, this is important. The standard of care currently in the United States is removal of all the remaining lymph nodes in that area. Unfortunately, as I mentioned earlier, only 50% of patients in the United States actually have that procedure done. Part of the reason is because only 20% of patients, I know there's a lot of numbers right now and I apologize for confusing it, only a small percentage of patients who have a positive lymph node actually have additional melanoma found in the rest of the lymph nodes when we take it out. There are a lot of factors in that, one of which is that we're now giving the pathologist, instead of one single lymph node, to look at a big bucket of lymph nodes, and it's harder to find even a single cell of melanoma there. There may not be melanoma in those lymph nodes, or it may be that we just didn't look in the right way. And it's also a complicated procedure. Taking out all the lymph nodes is much more complicated, as I mentioned, than just taking out the sentinel nodes, and it makes people a little anxious about offering it. And I'll show you a picture of that in a second. So in response to that, we have a trial called MSLT2, and you should know that that's available. It's not available at Emory for a number of reasons we can discuss afterwards. You can ask me about it. But we chose not to open that here. But what that does is it randomizes patients who have a positive node to either having the rest of the lymph nodes removed or being closely watched. The bottom line is I'm not comfortable closely watching people yet, so that's why we didn't open it here yet. But that trial is available in the United States because we're trying to answer that question. And so if your doctor says you should go on that trial, that's a good choice. That is a good choice. So this is one of the things that happens. This big incision here, that can lead to a lot of complications. And at least a couple of you in the room have had that big incision. At Emory, we decided that was too big of an incision, too much risk to the patient. And so we modified this, and we made this. This is called a videoscopic groin dissection. We're the only center in the world that are doing it. We have a trial open that's comparing the two. But it does change the outcome from this big cut to these little cuts. Ideally with the same outcome, it certainly appears to have the same surgical outcome. And so hopefully maneuvers like that will increase the number of patients who get offered the procedure, because we don't want to have people not getting the treatment that they need. So what happens if it goes beyond the lymph nodes? Well, I'll tell you a story as I close here. Clinical trial remains a good and perhaps the best option, but I'm going to leave that to Dr. Lawson. It should be performed if you're on a clinical trial in a comprehensive melanoma center. There are now efforts, because a lot of these trials are sponsored by industry, to expand these trials to community centers, to private institutions, to non-academic centers. The problem is, and I want to use an example of ipilimumab, which you'll hear about later, but ipilimumab is a very promising drug. Many of you may have read about it. It's shown a lot of interest and encouragement. The problem is that the complications from ipilimumab require someone on the surgical and gastroenterology side who are familiar with the complications and the disease and the drug. And if you're at a private setting and your oncologist knows about it and you have a complication, you have to be concerned that the other people who are going to be caring for you don't know what to do. And that's why when we have trials open at centers where there aren't comprehensive melanoma programs, you have to be cautious about that sort of thing. So I really strongly encourage you, if you're going to pursue a trial, pursue it at a place where there's a comprehensive melanoma program, where there are other people besides your oncologist or your whoever's offering you the clinical trial that know how to care for you. I hate to say this in this environment, but newer therapeutics right now, meaning things like ipilimumab or the BRAF inhibitors, which you're going to hear about, are not the holy grail, as the New York Times would have you think. They are definitely encouraging. We are definitely on the right track, and we have more promise in the past 5 years in melanoma care than we've probably seen in the past 20, and I'll defer that wisdom off to Dr. Lawson. But we certainly are encouraged by all this, but I don't want anyone to think that we're done yet. We have a lot of work ahead of us, and there's still a lot more things to think about, and a lot more questions to answer and to ask. But there is the promise, and we are beginning to unlock some of the mysteries. So the story, Don Morton, again, the guy who essentially invented sentinel node biopsy for melanoma. He actually started a trial called Canvaxin, which was really where his heart was. It's a vaccine-related trial several years ago. Reported the results of that study at a huge talk at the Society of Surgical Oncology, and it turns out that he got up and he said, look, this is the largest randomized trial ever performed in melanoma. But it turns out the trial was a failure. And he got up in front of all of us and said, it was a failure. But Don's a smart guy, and he didn't actually say, well, it's been a failure. What he said was the following. We stopped the trial at its interim analysis because we weren't showing a benefit to the vaccine. But you know what? You need to know a little bit about the trial. Enrollment for the trial required the surgeon to remove all of your disease that you had before you could be enrolled in the trial. And that's called stage 4 NED, no evidence of disease. So the patients had to be rendered stage 4 NED. And those patients that were rendered stage 4 NED, he says, turned out they had a remarkably improved survival. In fact, not to startle anybody or scare anybody, but we say that the median prognosis for stage 4 patients with stage 4 melanoma is 6 to 9 months. And we've certainly had people in the room that have lived much longer than that with stage 4 melanoma. We've cured many people in the room. And sometimes it's just because of the biology of the disease. And sometimes it may be because of our interventions. It turns out that in that group of patients that he looked at, there was a 40-month median survival from this time of initial surgical intervention. Didn't mean that the cancer didn't come back. In fact, in 8 months, the median recurrence-free survival when the cancer came back was only 8 months. But a 40-month median survival. When you compare the two numbers, 6 to 9 months versus 40 months, he said there has to be something there. Now, the problem, without getting into details about that type of analysis, is that it's not a valid statistical analysis. So everybody said, thank you for letting us know. We'll keep it in mind, but it doesn't really mean anything. And it turns out that 15% of patients underwent more than one resection. And there are clearly people in the room that have had that done too. I apologize. But nonetheless, it turns out that Don's not a stupid guy. And so he said, okay, well, we'll answer this question then. If there's smoke, perhaps there is fire. And so we now are in the process of opening here, and it's open in other centers in the country, a trial that's actually going to look at that. Just that. Does surgery really help for patients with limited stage 4 disease or not? And that trial is actually a very important one also, because if there's any truth to this, then we need to consider surgery in patients who are appropriate for it. Patients who are appropriate for it. So what do you take home? Well, some simple things. Your initial evaluation should be old-fashioned. A complete physical exam, a history. Things your doctor should really know how to do. But most importantly, no one knows your body better than you do. And if anything comes from this today, I want you to be empowered to examine yourself and recognize things that are different and changing, right? There really, and I say this a little bit more heavy-handedly than perhaps I should, but there really is no role for routine radiology or blood tests, particularly early on in the care of melanoma patients. And surgery, whether it be by your dermatologist, your plastic surgeon, your surgical oncologist, surgery remains the mainstay of initial therapy for melanoma. You should be offered a sentinel node biopsy if it's appropriate. It should at least be discussed with you, all right? As I mentioned, most patients with lesions more than 1 millimeter and patients with high-risk lesions less than 1 millimeter in depth. Removal of the remaining lymph nodes is the standard of care unless you're put on a trial. I can't stress that enough. If someone actually takes out a positive lymph node from you and offers you something other than surgery, they better have a good explanation for you, either putting you on a trial or you should ask to have a second opinion. And patients with metastases spread beyond your lymph nodes, you should consider a trial if you're not on therapy that you're comfortable with, and you should at least discuss the options for trial, especially if they're not available to you locally. Have we made progress? Well, this woman had her wide local excision in 1957. She came to me with a new melanoma. She's 87 years old. And you can see here, this is a pretty long incision from groin to knee, because back then, 5-centimeter margins. And I remind you where we are now, right? So maybe we have. Thank you very much.
Thanks, Dr. Delman. I'm David Lawson. I'm the medical oncologist. I was born here, and I just more or less stayed here for a while. I want to go over some of the emerging medical treatments for advanced melanoma. Reinforce what Dr. Delman said, though, that whenever patients come to us with advanced disease, surgery is always the first thing we think about. And, some of you in here know that because you've been through that, but that's always the first thing we think about. But we're starting to make some progress now in the medical treatment of melanoma, and I wanted to go over a few of those things with you if I could. The first statement to say, the take-home message, new things are becoming available. We have chemotherapy. You've heard of BRAF inhibitors. You may or may not have heard of secant inhibitors. Those are two major categories of drugs that are becoming available. And the importance of these newer chemotherapy agents is that they are getting increased specificity because they're attacking specific mutated genes that are important in melanoma growth. And what that means is that before, it's not like people before were idiots and they were just doing things randomly, but the specificity often wasn't there, and there's a great deal of overlap in toxicity with drugs that would harm normal cells and as well as the cancer cells. And so we've made progress in that we can now be more specific, at least for some patients, with some of the drugs. If you look at immunotherapy, some of the progress there is because we're better understanding the normal immune response and are better able to target specific parts of that, and hopefully to advantage of patients. I listed some agents there that we'll talk about. This isn't necessarily all of them, but it's sort of reflects to some extent our interest in things. But there's ipilimumab, or IPI, which most of you may have heard about. And then there's a vaccine which has made some press lately. There's another vaccine, MAGE-A3. Oncolytic viruses, which is something that's been of interest at Emory for years. Dr. Murray was one of the first people to ever start working with oncolytic viruses, which we'll talk about later on. Then people take IL-2. There are attempts to try to target that better so that we can reduce the toxicity. And then there's a new set of drugs called programmed death ligands, which we'll talk about a little bit. But this is just a partial listing, really, of some of the things that are becoming available. And you'll notice the key word in both of those is specificity, or specific, that people are getting better at being able to say what specifically you want to do rather than a more broad, widespread stimulation of the immune system or whatever. Well, I thought, well, since we're talking about BRAF and secant inhibitors, we need to talk about, well, what is BRAF anyway? I think both of these things are normal genes that are involved in cell growth. So BRAF by itself is fine. Everybody has it. If we didn't have it, we'd be in trouble. Same thing with secant. They're fine. The problem is when they're mutated or when they're changed in some way, they can become insensitive to normal growth controls. So it's like a car out of control. It won't stop when it sees the red light, and it won't stop when it sees danger coming or anything of that sort. So this was an insight that I guess to some extent it's common now, but it was only in the late 70s and 80s that people really began to appreciate the fact that normal genes get mutated, and that's what causes cancer. It's not as if cancer is some totally foreign thing that comes in. And so there are even names for these, and we call a normal gene that when it's mutated can cause cancer is called a proto-oncogene. But the mutated forms are called oncogenes, and that's a word you've probably heard. An oncogene is a gene that can cause or contribute to cancer. And BRAF and secant, when they're mutated, are oncogenes, and that's what they do. They help promote the growth of cancer, or to some extent can be causative of cancer. So, is a single oncogene enough to cause cancer? And usually not. One of the other insights has been that cancer really is an accumulation of problems. It's a lot of insults that have happened to that cell. It not only learns to grow, but it learns to invade other tissues, and it learns to cause its own blood supply to improve. So it has a lot to do. And as something of an example of that is many normal nevi or normal moles have the mutated BRAF gene. So they have the oncogene there, but they don't know how to do all that other stuff. And so they don't become cancer, or they're not cancer at that point. So as a corollary to that, or one of the things we have to learn is, like Dr. Delman was alluding to, just blocking any one gene is not likely to completely cure most cancers. It can help, but it won't likely cure them. And that's something we'll have to deal with as we're going through and developing combinations and trying to figure out other things that we can do to help. So what about BRAF inhibitors? I mean, this is the one that has gotten the most attention, deservedly. Some very good work by a lot of investigators. So if you come to us and you're interested in thinking about taking a BRAF inhibitor, the first question is, do you have that mutation or not? Because if your BRAF genes in your tumor are not mutated, then those drugs are not going to help you. You know, it's very important that you have that specificity. Well, and not only, I should say, do you have to have a BRAF mutation, but it has to be the right one. The drugs target a very specific mutation, but if your mutation is different, then those drugs are not likely to help you. Now, the sort of bottom line is that a little over half of melanoma patients do have the sensitive BRAF mutation. They tend to be a little bit younger, and they tend to have melanoma on sites that are not chronically exposed to the sun. But you can't really use that. Essentially, if there's a question of a patient has the mutation or not, then we go ahead and would test the tissue. Well, what is that? Well, let's see, I'm a little ahead. So what does that mean? What it means is we would have to get some of the tissue from your tumor, and we send it off to a lab. It usually takes about a week or so. And then they come back and they tell us, all right, this patient has this specific mutation, or the patient does not. And then we would get back in touch with you and say, based on what we found, this is what we can think about doing. Well, what if you do have the mutation and you do decide to take one of those BRAF inhibitor drugs? Well, the good news is that about 80% or so of patients, maybe a little less as time goes on, will actually show some improvement. And the improvement can happen pretty quickly. But it unfortunately tends not to be complete disappearance. Well, most of the time it's improvement, but it doesn't go away. And this gets back again to what Dr. Delman was saying. We have to be cautious about how we present these things to you. And this improvement tends to last some number of months. Now, it can be out as far as 18 months or more, but for some people it will be less than a year, and then we kind of lose that improvement. And what's happened? Why is that? Well, it just means that some of those other mutations that cause that cancer cell to be a cancer cell have sort of taken over, and they're now driving, and the mutated cells are no longer important, or that the cancer cells have changed in some way, and they now are able to get around this block that we put up in their path. Well, the side effects tend to be mild, which is good news. I mean, they're arthralgias and fatigue, and to us what we call mild fatigue is patients still able to get around and take care of themselves, may or may not be able to work, but they're not debilitated or anything of that sort. And there's some nausea, but It's one of the interesting side effects to us is there's a fair number of skin problems that happen with these drugs. People get photosensitive, they get a lot of itching. There's a palmar plantar dysesthesia, it's called, which means they can get pain on the palms and their soles of their feet. But one of the more interesting ones, and this again, this is why cancer is hard, about 30% will develop other cancers, squamous cell cancers of the skin. Now, fortunately, as Dr. Delman was saying, most of the time squamous cell cancer of the skin is a nuisance. You just have to take it off. And that's the way these typically are. They're a type that Dr. Washington, Dr. Chin, take it off, send it off, no more problems. But it's interesting that you have a drug that attacks cancer, but on the other hand, it can cause cancer. And that's, as I say, a nuisance, but it's one of those things that makes it difficult sometimes to sort through all this. Well, what's the current status of the BRAF drugs? There's been a phase 3 trial already completed. Phase 3 is when a drug is compared to a known standard. And in this case, it was DTIC, which some of you know about DTIC. That trial has been completed. There was, as you may recall, discussion in the New York Times about it because there were a lot of ethical issues surrounding the fact that some of the patients who participated in that trial know they have the mutation, but they never got the drug in that. And there were 2 brothers, I think, who were both in a trial, one did, one didn't. These are tough issues, and I don't propose to get into them. If you want to discuss it, the question we can, but the trial has been done, and early indications are that it's a successful trial and that the drug will be available sometime this year, hopefully. But in the meantime, it's available on what's called expanded access. And so, now this doesn't happen overnight, but increasingly the drug is more and more available to anyone who has that mutation. There are other BRAF inhibitors being developed, and as was alluded, people are looking at ways to combine these drugs with other drugs so that we can get that time period lengthened. The secant inhibitors are less far in development. This is a drug that you may recall caused a lot of stir in chronic leukemia when it was one of the very first drugs, some of these drugs, to target a very specific abnormality in CML. And they're also used in GIST tumors, which are stromal tumors and that. But the main thing is that the secant mutations are a lot less common than the BRAF mutations, and they tend to be found in patients who have mucosal melanomas, which are like in the head and neck, in mucosal surfaces, not on the skin. And palms and soles, which this is non-hair-bearing skin, so it's a little different than hair-bearing skin. And then perhaps in chronically sun-damaged skin. Now, the development of these is not nearly as far along, but it's coming along as well. And it will be a help to some patients, but not nearly as many as the RAF inhibitors. So to move on to immune therapies, we have ipilimumab. Ipilimumab is the one that has gotten the most attention, and deservedly so. It's the furthest along. If you think about what does ipilimumab do, this again we're shifting now over to the immune system. The normal immune system has mechanisms to turn itself off. So if you get a cold and you get an immune response to that cold, I'd always just thought, well, once the virus is gone, the immune system shuts itself off. But that's not actually true. It actually has to have specific mechanisms to turn itself off. And one of these mechanisms involves a molecule that's called CTLA4. And so ipilimumab blocks the CTLA4. So it's basically like taking the brakes off, is the analogy that people have used. The immune system has a system, so you get going fast, and it puts on the brakes. And ipilimumab stops you from putting on the brakes. And that's what people are attempting to accomplish with it. And of course, the thinking is that if you've had an immune response to your cancer, but your body, not knowing any better, shuts it down, then maybe if you can relieve that, take off the brakes again, then you can get some improvement. So how effective is it? This is sort of the opposite from the BRAF. BRAF, most patients get benefit, 80%. IPI, most patients unfortunately don't, for reasons that we don't understand. But about 20% or so will get remission, not necessarily remissions, but either stable disease or improved disease that lasts for years. Now, it may be many years, it's just the drug hadn't been around long enough to say, about 10 years and things like that. We just don't know. And patients don't need to be on treatment to get that. In other words, you take your treatments and what happens, happens. And for many patients, they'll stay in that stable state or improved state for many years without having to take anything else, which is a good thing. So it's kind of the yin and the yang, if you will, in that you've got some, with BRAF inhibitors, high response rate, short duration. With IPI, low response rate, long duration for the patients who get the response. The side effects are a little more complicated for IPI. Some of these are acute, and they're related to the fact that it's a monoclonal antibody or an antibody against the CTLA4 molecule. But most of the severe ones are related to the fact that IPI takes the brakes off the harmful immune responses just like it does the good immune responses. And I think it's probable that most of our bodies at some time in our lives try to do something mischievous and attack normal organs or something of the sort. And there are diseases that are recognized as where patients do get an autoimmune disease. Their immune system is attacking themselves. And IPI can enhance that some. The most serious is the colitis. This is the immune system attacking your colon or your bowel. And it can be severe enough to actually punch a hole in the bowel and cause a perforation. And this is what Dr. Delman was alluding to. I know when we start out doing these things, people didn't know that was likely to happen, and it was a big problem. But since then, surgeons particularly and gastroenterologists have worked out with medical oncologists ways to try to anticipate these things and then intervene surgically or whatever we need to do so that you don't get to that perforation. Now, that's not it's not like huge numbers of patients will get to that point, but some will, and for them it can be even fatal. You can have an autoimmune hypophysitis. That's your pituitary gland, which controls a lot of the endocrine function in your body. That happens sometimes. Autoimmune hepatitis, which will go away if we stop it. A lot of skin rashes, which keeps the dermatologist busy. A lot of fairly complicated skin rashes that can happen. But for a lot of patients, the ipilimumab is well tolerated, just like the BRAF. I mean, patients will go about their normal activities and be able to do most things they can do, sometimes not even aware that they're taking the drug as far as their side effects are concerned. So what's the status of IPI? There's been a phase 3 trial of that too. And what happened in that trial was that the IPI was compared to a vaccine, and it was clearly superior to the vaccine. And so in FDA speak and in our thinking about things, the fact that you show yourself to be superior to something else is one of our real hallmarks of whether a drug is worth exploring or not. And that's happened. And it's currently available on an expanded access basis. We anticipate FDA will rule on this sometimes in March, and anticipate it'll be favorable, but you never know. But then even after that, there'll still be a little lag while the company has to gear up production. These things are not easy to make, and particularly to make them safely. But already people are starting to explore how to combine ipilimumab or IPI with other immune therapies so we can try to enhance on that 20% of patients who are clearly getting benefit. I just wanted to take just a minute each on some of these things just to give some other flavor to what's going on. This GP100 vaccine, GP100 is a protein that is expressed on most melanoma cells, but not all of them. But it's also expressed on a lot of melanocytes and normal cells as well. But a vaccine was developed, which basically is part of the GP100 protein. The idea is you vaccinate people so that they will generate an immune response against the protein, whereas perhaps they didn't before. So it's pretty inactive by itself, but in a recent trial that has been discussed, some of you may have read about it, when you combine it with IL-2, there actually was some modest benefit to adding in the vaccine. Some of you here may have taken that. But future development that's not clear, and the reason for that is it's a modest benefit, and people are thinking there may be better vaccines, but it's a proof of principle. You know, the vaccine approach to melanoma, again, Dr. Murray was one of the first to start working with that many, many years ago, but is still inching its way forward. And this is one of the first positive trials that we've had. But now here's a MAGE A3 vaccine. When I said that there may be better vaccines, GP100 is expressed on a lot of normal cells as well as on melanoma cells. But this MAGE A3 protein is mostly expressed on cancer cells. You know, melanoma cells, about half maybe, also some other cancers, but most normal cells don't have that protein. So that's a good thing. And so people are thinking this will be a better vaccine in the sense that you can make an immune response against it that won't bother normal cells at all. And hopefully a stronger immune response, since the body's really not used to trying to carrying whether you make immune response to MAGE A3 or not. So there's a trial ongoing right now to try to see whether this vaccine will prolong survival in patients who are surgically NED, as you know, no evidence of disease, but at high risk for recurrence. So this is another approach that people are trying. This is an oncolytic virus that's engineered to secrete GM-CSF. Well, what's an oncolytic virus? It's kind of neat. You know, an oncolytic virus is a virus that will infect the cancer cell and then kill the cancer cell. And it won't do that for all of them, but it can do it for some of them. And these dead melanoma cells that are there can incite at least some immune reaction just because there's dead tissue there. And so GM-CSF is something, again, some of you may have heard about or taken even, can enhance that immune response, at least as we understand it. So what people have done, molecular biologists, they take the virus, it's kind of cool that they can do this, and then they put in a segment of DNA that makes GM-CSF. And so what you do is you inject this virus into the tumor, and in the best of circumstances, not all of it, but in the best circumstances, the virus kills the cancer cells. All this immune response comes, and the GM-CSF is right there. So it augments it and makes it better. So our ideal is that we're going to be able to get not only some local response killing the tumor, but a systemic response as well, that these cells stimulated by the GM-CSF will go out and hunt down other melanoma cells. So there is a phase 3 trial again. It's comparing this approach to the GM-CSF, virus injected into the tumor. And what we'll see over time is whether, in fact, for some patients, we're able to see some improvement, not only what we inject, but in other tumors as well. And it's early, all you can say is we're hopeful, that kind of thing, but again, not any more than that. Dr. Delman actually worked on that virus when he was young, you know, younger. But, yes, it's one of those things that it's a great accomplishment, and I did want to give credit because he did. All right, targeted IL-2, I'll just say about this. IL-2 is FDA approved. It helps about 15% of patients, but only about 5% get these really long-term remissions. But the major problem is the toxicity, and so there's a new compound that we're trying to work with that ideally is going to make the IL-2 more go just to the tumor and not to every place else. And so we're hoping that we can get the same effect by localizing it to the tumor and not have quite as much systemic effect. Time will tell. And this, again, is based the same theme. Some melanomas make a specific protein that's called P53, and if they make that and you can hone the IL-2 in on it, you have a chance of some specificity. So again, same theme, specific antigens trying to accomplish specific goals. The programmed death ligand system it's another way the body puts the brakes on. And again, people are trying to work on that. And I just mention it because it's in way early development, only to say that there are more things coming down the pike, even more than we've mentioned here. So I'd say conclusion, I say to us at any rate, as we said earlier, we fight this in different ways than you fight this. But on our side of the fence, this is the best kinds of improvements we've had in all my years of doing this. You know, you'd have to say that more progress was made in the last 5 years than in the rest of my professional life put together. So it goes, you know, but there are real advances, and they're real. They're not pie in the sky, and they're not smoke. They're not the Holy Grail, but they're improvements, and they're important. The theme we've been trying to say is they're based on a better understanding of melanoma and also the body's response to it. Specificity is the thing. As we get more specific, the number of people you help may go down, but at least you can identify those people, and you'll be able to help them better. Leads to more specific treatments. And the other thing I would want to say is there's only one reason for us not to have more advances, and that will be if we stop trying. And we're not going to stop trying. I know Valerie's not going to stop trying, and I know you guys are not going to stop trying. And I think as long as we keep plugging at this, there will be more improvements. And when we come back in a couple of years to do this again, we'll be talking about how we used to do all that stuff, but now it's better. At least we hope. Again, thank you all for coming. I think we get a break now, right? Do you want to tell about the break?
Words, yeah.
And that?
So I actually want to digress for 1 minute and talk about something that Dr. Delman spoke about, indoor tanning. I wasn't going to do this, but since he brought it up. So melanoma has now become the #1 cancer killer of women 25 to 29, and it's the second largest cancer killer of women 30 to 34, right behind breast cancer. And I think that most people believe that indoor tanning certainly plays a major role. So one of the things we've been doing at AIM for the last 6 years is we've kind of led the fight to ban indoor tanning for minors under the age of 18. And I like to say that when I started doing this 6 years ago, it was probably the only thing that as a small foundation who couldn't afford more than to buy a business card could do. Dialing for dollars, I would call state senators and representatives across the country. Very cheap to do that. So when I started, there were 3 states that had some kind of legislation in their state senates, and last year, not that they were all passed, but we did manage to get 25 states to introduce some sort of legislation. I will say that Georgia has been very, very tough. We have made almost no progress. So this year, we've got, I think it's 17 states, because hard to get 25 again. After a state has done something, whether it's passed or failed, you have to wait a couple of years before you come back. But we do have some very major states that are looking to ban under 18. Illinois, Ohio, New York. So if any of you in this audience happens to have any kind of relationship with a state senator or a state representative and would like to talk to me about it, I mean, we do all the work. We bring in the American Cancer Society. We bring in the American Academy of Dermatology. We get people like Dr. Lawson and Dr. Delman to come and testify. So we do bring that representative or state senator a complete package. And I think that, you know, we would all like to see tanning under the age of 18 banned across the U.S. It's been banned in Australia and in England and in India, but some places are just tough. So now to do the housekeeping very briefly, the restrooms are on the way to the elevator on the left-hand side. If you have questions, and can drop them off at the registration desk where you registered as you came in. And also, if you could give us your email addresses if we don't have them. If you registered online on our site, we have your email address. But as I said before, we are having this filmed, and we'd like to be able to email you the link so that you can view this. And then last but not least, a 15-minute break. We've got a very full second half session, so if everyone could return promptly, we would appreciate it.
Valerie, can I
Yeah.
just say something right quick to the audience in response to your comment about Georgia? My name's Marilyn, I have an oncologist for skin cancer, but just this week, this Tuesday, we did a Skin Cancer Awareness Day at the state capitol. And we're bringing dermatologists, and there has been some legislation that was passed last year for tanning beds here in Georgia where you have to have approval for under 18. We hadn't banned it, but the Atlanta Association of Dermatologists, which Dr. Washington has been an officer and will be the upcoming president next year, and the Georgia Dermatology Association, they do work a lot with the legislators, and we are working toward that project. So Valerie and I just talked today, and I do want to talk to you later about that, but we are doing things to help to get that legislation passed.
Thank you. Hello, everyone. So I'd like to introduce this works so well in Atlanta, doesn't work so well in the Northeast. So I'm glad you're all back. So we have a very filled second half of the session, and I'd like to introduce Dr. Washington.
All right, thank you very much, and thank you all for coming. And so we're going to, at this point, conclude the presentations with myself and Dr. Chin, my partner in dermatology, and we're going to back up a little bit from what you heard from Drs. Delman and Lawson and talk about what we look for. So when you guys come to the dermatologist and wonder what it is that we're focusing on and what gets our attention, what doesn't get our attention, we're going to try to focus a little bit on what those things are and then what we do once we see something that we think looks suspicious. And so just as a point of information here, I have no relationship with any industry. I'm not talking about any products, but it's important to know that we have no relationship with these entities. And so hopefully what we'll do at the end of this brief presentation is just give you an idea of what some of the risk factors are. Who's at risk for melanoma? And what are some of the differences between the 4 different clinical subtypes? We'll talk a little bit about that. How one would perform a biopsy, and then you heard a bit about the relationship between the tumor thickness and then what Dr. Delman will do. And so you heard some of these numbers. The actual number of new cases of skin cancer in the country each year is related to kind of what database you access. So if you look at the American Cancer Society, there certainly are at least 1 million new cases a year, but if you look at some of the information that you can glean from the Medicare database on what people are reporting, physicians are reporting in terms of diagnoses and procedures that they perform in their office, the number may be much higher. We're seeing an increased incidence in all age groups. You've already heard the importance of the incidence going up in younger women. The majority of these are basal cell and squamous cell cancers, but the list of other types of skin cancers are very long. We're not going to talk about those, of course. So where does melanoma come from? And we get this a lot. We talk about moles and we talk about pigment in the skin. Well, if you look at the very top layer of the skin, the epidermis, which is maybe several sheets of typing paper thick, along the very bottom of the epidermis, there are these cells called melanocytes. These are the cells that produce pigment in the skin. And amazingly enough, everyone in this room has the same number of melanocytes, if you will, per square area. But people who are darker, like myself, produce more pigment in those cells than those who are more fair. And these cells, the melanocytes, not only contain pigment within their own cell bodies, but also distribute their pigmentation to the cells in the upper epidermis called the keratinocytes. The keratinocytes are the cells that lead rise to basal cell and squamous cell cancers, the other cancers. So again, you've heard that this is a common cancer in young adults, and the cure rates, as Dr. Delman alluded to, are very high for people whose tumors are caught early. And so this is one of the things that we'll emphasize over and over. We've heard about all of the wonderful new techniques and technologies that are available from Drs. Delman and Lawson, but our job as dermatologists is first to keep you out of their hands. We should be able to do that by careful skin exams as much as we reasonably can. You've heard that melanoma causes a significant number of skin cancer deaths, and the number of new cancers each year is on the rise. What's interesting about melanoma, as you all know, is that a significant number of these tumors will be found in individuals who are younger. So this is not primarily a cancer of the senior citizens, but often younger patients. And Dr. Delman also alluded to the fact that the risk is increasing, and this is another way of kind of looking at the numbers that he cited. And if you look at what was happening before World War II, the incidence was about 1 in 1,500 people, but now it's somewhere around 1 in 75 or 1 in 80 approximately. And we think this is related primarily to recreational habits. Before World War II, there weren't mountain bikers and long distance runners to the degree that there are now. Everybody wasn't out playing golf, et cetera, et cetera. And so changes in recreational habits, probably among other factors, are some of the leading reasons we believe that the incidence of melanoma is on the rise. You also heard that there is no one simple explanation for why a person gets melanoma. And there are a whole host of factors that I've listed here that may form a piece of the puzzle. Patients often ask us, well, what's my risk of getting melanoma? And it's not a question that we can answer with a single simple answer, but it depends on looking at every piece of the individual's puzzle and trying to put together a risk profile. And the factors that are important are certain genetic mutations. You're going to hear a little bit more about this from Dr. Chin. Whether or not others in the family have had melanoma. Certainly you hear over and over about ultraviolet radiation, tanning beds, how much time a person's spending out in the sun, especially how much time a person spent early in life, the first 15, 20 years of life, and how many times that person had bad sunburns, especially blistering sunburns. That appears to be important for melanoma. When we talk about basal cell and squamous cells, it seems to be related to kind of a chronic cumulative exposure over years, but those repeated intense exposures early in life probably play a greater role for melanoma. The number of moles a person has, since melanoma can arise in a mole, the number of moles you have intuitively, perhaps the higher the risk. Congenital nevus or dysplastic nevus, we'll talk about those. Those are unique precursor lesions in some instances. Dr. Delman mentioned a personal history of melanoma is a risk factor for getting another melanoma. The good news is most people who get one melanoma never get a second one. So it is a risk factor, but it's not going to happen that multiple melanomas are going to occur in the same person. There are a number of other factors. Higher socioeconomic status in some data suggest there's some indication that may be important. We talk about skin types. The dermatologists think about skin in categories 1 through 6. A type 1 would be the person who had green eyes, red hair, freckles, unable to tan. A type 6 would be an African, and so every grade in between. And so the lower the number, the higher the risk. Those who grew up closer to the equator, and then there are a host of other factors. As we see more patients who've had organ transplantation, had their heart, kidney, liver transplanted, those individuals who are on chronic immunosuppression may be at increased risk of developing melanoma. So interestingly enough, there are 4 different, if you will, flavors of melanoma. Now, when we talk about the depth, a melanoma that has a certain depth of 1 millimeter, for example, that Dr. Delman alluded to, the behavior or the risk is not different for these 4 types, but we make a point of discussing these because how they present and where they present on the skin is important. And the most common of the 4 types is what we call a superficial spreading melanoma. And this is the most common one, which occurs generally in younger to middle-aged folks, can occur anywhere on the body, but predominantly the trunk and the extremities. This is the one that starts out as a small, flat, brown spot that gradually gets larger and then ultimately starts to get a little bit thicker. Some of these arise from a pre-existing nevus. In other words, your dermatologist is always looking at your moles and trying to decide if a mole is changing. It's important to realize, and we say this over and over, that not every mole is going to become melanoma. And most melanomas do not appear to arise from an existing mole. Most melanomas appear to pop up as melanoma. So this becomes an important question when folks ask us, well, why not just take all the moles off and get rid of all of the risk? And the reason is you can't do that. Most melanomas arise as a melanoma. So just looking at some examples, I think these are kind of the textbook classic examples that everyone would expect to see. We talk about tumors that have these irregular borders, what we call a scalloped border. that are asymmetrical. If you draw a line down the middle, one side doesn't appear to match the other side. There's irregularity in color, and the size may be larger. We often talk about it being important if it's larger than 6 millimeters, which is about the size of the eraser on a pencil. But of course, melanoma starts small and grows, and what that latter point means is that often at the time that the melanoma is diagnosed, it's larger than 6 millimeters. But they start small and they grow, of course. You may have instances where, again, one that started as a flat area ultimately develops a little bump in it. There are instances where a tumor which was uniformly brown or darker in color or black may develop what we call regression, where the pigment appears to be lost in the center of it. And this seems to correlate when the biopsy is performed, it seems to correlate sometimes with the body mounting an inflammatory or immune response against the melanoma cells, but unfortunately this is not always something that turns out to be a positive factor. And again here I think you can see asymmetry, irregular borders, irregular color, all of the A, B, C, Ds that you've heard about already. These tumors can occur in darker skinned individuals. Most times, remember, they're in types 1 and 2, but they can occur in any race. Nodular melanoma, which is fortunately not the most common one, is more concerning because this is the type that generally occurs on the trunk, generally in middle-aged or older men more than women. And it's unique in that it doesn't appear to grow laterally or horizontally on the surface of the skin initially, but starts out usually as a lump. These are the ones that can grow a little bit faster. As you heard earlier, these things don't grow overnight, but this one probably grows faster than the other types that we'll talk about. But while this is one that can have an unusual appearance, specifically it may not be pigmented. It may be what we call amelanotic. Remember, we always talk about brown and black things, but as Dr. Delman pointed out, not all of them are pigmented. But there are clues that we can have when we're looking at a nodular melanoma. Well, these are examples of tumors that kind of grew rapidly as a little nodule here. They often will ulcerate or get a little area that breaks down in the center. They get kind of crusty on the surface, kind of a scab, which correlates sometimes with ulceration, and that ends up being an important one of those risk factors that Dr. Delman talked about that the pathologist can also see and indicate that helps guide treatment. They can, again, ulcerate commonly, as you see here. This is just a close-up of this tumor here. But a more classic is one in which, a more classic presentation would be one in which you have a little nodule. It looks harmless, but it's growing rapidly and it's spontaneously ulcerating or eroding. The skin is breaking down spontaneously. Now that's something that can occur in benign growths, but when you see that combination of things, particularly on the trunk of a middle-aged man, the degree of suspicion should be higher, and certainly a biopsy would be warranted. Lentigo maligni, I always say if you got to get one, this maybe is the better one to get because this is one that grows very, very slowly. It has the longest what we call radial growth phase, meaning where it's growing on the surface of the skin and not invading into the skin. These occur later in life, primarily on sun-exposed areas. And just like the other superficial spreading starts out as a small brown spot, the classic example in my practice is, oh, it's just a liver spot, it's just an age spot. But it's one in which it stands out against the others. Here's an example of where someone has what we call lentigines, these sun-induced spots, but this is clearly different than the others and starting to get a little brown spot. Same thing here, clearly not a liver spot, right? Same thing here, they can occur around the eye, we commonly see that. They can occur around the mouth and around the nose, but primarily sun-exposed areas. So this acrolentiginous type, slow growing, but commonly on areas where at least cosmetic concerns are important. And then, excuse me, in instances where it's not treated, either by patient decision or other factors, they generally progress, as I mentioned, to a flat area to one in which you can get larger or thicker areas within the lesion. And then the last type, called acrolentiginous melanoma, also occurs a little later in life. This is the one that can occur on the palms, the soles, can occur in the mouth, the genital area. Melanoma is relatively uncommon in African Americans and Asian Americans, but when it occurs, it is often this type. And this one also starts out as a flat area that gradually gets wider and ultimately gets thicker. This is often one that can also occur under the nails, under the fingernails, under the toenails, and we see lots of patients at Emory who are sent in to evaluate streaks under the nail. We'll show you what that looks like. But these are kind of more classic examples of acrolentiginous melanoma. There is some evidence that these are often not caught as early. The misconception is that, well, if it occurs, if a mole is on the sole of the foot, it's inherently bad, and there's no truth to that. But the truth is that if it occurs on the palms, especially the soles, and those areas are not being examined, and you'd be surprised how often that's the case, that the bottom of the feet are not examined, it's possible for that growth to acquire a larger size before it's detected. And that's what happened in each of these examples. Again, you can see the large irregular areas on these surfaces. There's less pigment here, but there is a little bit there, which is a clue. Often these are misdiagnosed as wart or some other thing, but the occurrence of pigment or the presence of pigmentation near the area is a useful clue, or can be a useful clue. But sometimes it's more subtle. Sometimes the pigmentation is less clear, but other clues might be that you have ulceration or erosion there, or you've lost the ability to grow a normal nail. That can be a useful clue. There are all kinds of infections that can occur around the nail, bacterial and fungal infections, but they usually don't cause spontaneous destruction of the nail plate. So that occurrence makes you think more about the presence of melanoma than a fungal infection. Obviously, these are more advanced, thicker area on the bottom of the toe. Another example of the tumor occurring under the nail. Same thing here. Again, very subtle, right? But the pigmentation there is a useful clue. So we pay a lot of attention to that when we're doing the examinations. And sometimes they're even more subtle and can be in younger individuals. This is a child who has this very deeply pigmented streak. Oftentimes when melanoma occurs under the nail, and again, this is not the most common location, but when it occurs under the nail, it will often begin just as a streak like this. But over time, that streak might be getting wider, or the pigmentation that occurs under the nail may start to grow up on the skin here, or under the distal, the far end of the nail, also a useful clue. Other examples, this is an individual who worked in the dermatology clinic. She was a nurse in the dermatology clinic and slammed her finger in the door, a car door coming to work, and brought it to our attention, but the resident noticed that she had this little early streak here, and this was just the very beginning of a melanoma occurring under the nail in that finger. And then one of the things that Dr. Delman alluded to, which we talk about all the time, we dermatologists talk about all the time, at least here, is the importance of a full skin examination. There are some instances where a person who has seemingly one skin condition, and this particular patient had vitiligo, which is loss of pigmentation on the skin. When we ask her to allow us to examine their entire skin surface, she also had this melanoma under her toenail. And the association can occur between melanoma and vitiligo. And the goal is to catch things early to prevent circumstances where the tumor can spread. This is just an example of that type of melanoma occurring on the sole, spreading up the skin up towards the lymph nodes. So you've heard over and over about the A, B, C, Ds of melanoma, but remember the E. E is evolution. Is it changing? And Dr. Delman alluded to this. Oftentimes, and you'll hear Dr. Chin talk about the role of mole mapping, but oftentimes patients will zoom in on a mole so closely and start to see little details that may or may not be important, but then on further questioning, they'll say, oh yeah, but it's looked like that for 20 years. Well, the probability that it's been stable for 20 years and is a melanoma is pretty low, right? But sometimes a mole that looks fairly innocent but wasn't there last week could be important. So we put together A, B, C, D, but always is it changing. And you'll hear more about how we can remove some of the guesswork about whether or not a mole is changing. So one of the other things that we hear often is that, oh, I saw the dermatologist and he took or she took a big chunk out of my skin. She was concerned about it, he was concerned about it, took a big chunk. And one of the things that we feel is very important, and you've heard a little bit about this earlier, is the importance of doing a proper biopsy. And it's one of the key first steps in the management of melanoma. And so if possible, if your dermatologist sees something that they're concerned about, the thing that we want to do is, if possible, remove the whole thing as part of the biopsy procedure. Sometimes that's easy because it's small, sometimes it's harder because the suspicious area is very large. But if it's possible to remove the whole thing down to the subcutaneous fat, that's really what we should do. If it's not possible because the area is very large, then we'll take a portion of it, what we hope is the thickest area based on how it feels or the coloration. And one of the other questions we've heard from time to time is, well, if you cut through it, does that make it spread? And we have good evidence that that's not the case. But what we hope to get, the reason that the dermatologist or the other doctor will remove the area down into the subcutaneous fat, is that we need to get important information from that biopsy, which is related to the depth of invasion or the thickness of the tumor. And that's important because how thick the tumor is influences how much skin needs to be removed as the definitive procedure. So the biopsy itself is not the end of it, right? But that's where you get the information about how deep it is. Are the cancer cells just near the surface of the skin, or do they go down into the subcutaneous fat? And if that information is not acquired on the biopsy, it makes it harder then for the surgeon to decide, okay, does this person need a sentinel lymph node exam or not? If it was transected, as we say, shaved off the surface and not completely removed, and we know that the area appeared to be 0.8 millimeters thick, but it's transected, we don't know the real depth. So whether or not a sentinel node biopsy is valuable or not is unknown at that point. There are ways that we deal with that, but the bottom line is the biopsy should, where possible, remove enough skin to see the subcutaneous fat, which will give us then the Breslow depth, that depth in millimeters, not the stage, but the depth in millimeters that then will guide further decisions about surgery and or sentinel lymph node examination. I won't talk about this in any detail except to say that you notice there is a relationship between the thickness of the tumor from being in situ, meaning just on the surface of the skin, down to those that are greater than 4 millimeters. As the tumor gets thicker, the surgical margin gets thicker. And this is why we need to know that information going forward. So where possible, we want to see the full thickness, and that's why sometimes the biopsy seems larger or seems deeper than you might think it should be based on the size of the mole. And of course, it's all about preventing metastatic disease. We've heard about the progress that has been made for later stage disease, but the value and the important thing about melanoma is that we are so able to make an impact early on. So complete skin examinations by the doctor, self-skin examinations are important because if these are caught early, as you've heard now several times, they're mostly curable when detected early. I'm going to finish by showing you some examples of what we call precursor lesions. Remember I said earlier, not every mole is going to become melanoma. There are lots of pigmented things that occur on the skin, but most growths on the skin that are pigmented are not melanoma. But there are some types of growths on the skin that are pigmented that do potentially have some increased risk of leading to melanoma or forming melanoma. And the two main categories are what we call dysplastic nevi and congenital nevi. A dysplastic nevus is a mole which has many of the, a dysplastic nevus is a mole which has many of the features of irregularity that we saw with the ABCDs. It often occurs in the setting of multiple lesions, as in this patient, you can see multiple spots on the skin that, based on the criteria we've outlined earlier, would get your attention. Turns out at the time this photo was taken, none of these were melanoma as far as we knew, but we know that this is a person, because of the number of the moles and the irregularity of the moles, excuse me, has some increased risk. This is another example of a dysplastic nevus. Well, these may be familial or sporadic, meaning that they can occur in the setting of family members with multiple dysplastic nevi, or they may occur just spontaneously. There are probably multiple people in the room who have dysplastic nevi. And how important they are, again, it's all about a piece of the puzzle. How important they are depends on many factors. Depends on the total number of them that exist. Depends on whether or not that individual's had melanoma or other family members have had melanoma. And there are certain situations, you'll hear this, some of you may have heard dysplastic nevus syndrome, which is a term that gets used a lot. But dysplastic nevus syndrome is a unique entity, a unique situation in which a person has multiple dysplastic nevis in the setting of personal or family history of melanoma. That individual is someone that has higher risk of developing melanoma. Not every person with a dysplastic nevus has dysplastic nevus syndrome. So I kind of answered this question earlier. Remember, we get the question a lot, why not just remove them all? And the answer again is that most moles will never become melanoma. And so to remove, for someone who has multiple moles like the example I just showed, would be lots of surgery, lots of procedures for someone whose risk of melanoma is relatively low. And then finally, the other precursor lesion that you need to be aware of is what's called a congenital nevus. And a congenital nevus is a mole that's truly present at birth. Most of us don't have moles that are present at birth, but truly present at birth or shows up in the first few months of life may have an increased risk of melanoma based on the diameter. So the larger it is, the greater the risk. And when we get to very, very large areas, as in this poor child, the discussion has to happen about whether or not that mole should be removed. And as you can imagine, not a very simple thing to do. But they come in many different sizes, and again, we can make the decision sometimes early in life to remove them. Sometimes we make the decision to observe them if they're in an area where they can easily be followed. But it's a complicated and sometimes difficult discussion for parents. But these are the two main precursor lesions, dysplastic nevi and congenital nevi. And so, again, to conclude, one of the great opportunities we have with melanoma is that we don't need, to make the initial diagnosis, we don't generally need scans, we don't need blood work, we don't need any high-tech devices, just somebody hopefully with decent vision and knows what they're looking at, and just the time, taking the time to do a complete skin examination. So for patients who are at risk for melanoma who are followed in our clinic here, that's one of the routine things we do. We also like to teach patients the importance of doing it, and again, as Dr. Delman mentioned, by just looking periodically, you know your body's better than anyone else, you know if something's changing, and so just regular examinations is important. You've heard about the importance of avoiding unnecessary sunburns. Regular use of sunscreens is something that we emphasize, protective clothing, avoiding the midday sun. One of the things we don't want people to do is shut down and stop living. Of course, we want everyone to live their lives to the fullest degree possible, but in a smart fashion. If you enjoy jogging, then you should jog. But can you do it earlier in the day? Does it work just as well if you jog at 7 a.m. or does it have to be noon? If you enjoy swimming, does it work at 5 p.m. or 4 p.m. or does it have to be noon? And so sometimes changing the way that we perform our activities can have a major impact. And then finally, just for those who are at risk, a regular skin exam by a dermatologist. Usually an experienced dermatologist is pretty good at determining which lesions are significant or which ones aren't, but certainly can perform a biopsy when in doubt. But certainly someone who's used to looking at the skin, Dr. Lawson does a very good job at it, but those who are used to looking at the skin, it's important that periodically that complete examination through the hair all the way down to between the toes and the bottom of the foot be done on a regular basis to prevent and to detect lesions as early as possible. In 2011, we don't have any technology yet. We don't have any drugs that we can give and say, okay, you won't get melanoma. We have no way to prevent it, but all of our efforts can be directed at early detection and earlier intervention where we know the cure rates are still very, very high. And so that's a tremendous opportunity for us as dermatologists, I think. And with that, I'll conclude. Thank you. The next speaker will be my partner, Dr. Chin, who's going to speak about some of the other adjuvant tools that we have in dermatology.
So I want to thank all of you for being so patient and allowing me to be the last speaker, and hopefully you'll find what I have to say interesting too. So what I'd like to do is to roll it back even more. We started with the most severe scenarios of melanoma. Dr. Washington talked about the earlier stages of melanoma and what we need to do to try to help and find those, but I actually like to roll it back even more and start talking about some of the precursor lesions. So unlike my colleagues, I do have things that I disclose. I run the clinical trials unit in dermatology, and so we do cutting edge therapies and technologies and whatnot. And so the one that I want to point out to you is that I do some work with a company called Melisciences, and will refer to their product. I also work very closely with the Centers for Disease Control and Prevention in their skin cancer group. So you're in this scenario now. You've just been recently diagnosed with a melanoma, or maybe a family member had been diagnosed with a melanoma. So what happens now? And how do we catch these new melanomas, because now people are at risk for new melanomas. How do we catch them early? And what do all these biopsy reports mean? The dermatologist takes off one, you get a copy maybe in the mail, and they have all these words and phrases, and what do some of these things really mean? And then what kind of testing should I get done? There's all these new genetic testings and whatnot. So do I need it? And these are sort of the questions that I'm going to try to answer for you today. So I'm going to start out with some definitions just to show you how confusing our world is. Talk about some risks of developing melanoma, and then talk about some of what I call the adjuvant diagnostic tools. And so these are tools that we as dermatologists have with us to help us make a diagnosis of melanomas, and just to also show you what kind of tools are on the horizon. They're not prime time yet. And then I will conclude by talking a little bit about this CDKN2A genetic testing. So you've heard the words atypical moles, you've heard the words dysplastic nevi. What exactly do those mean? Well, unfortunately, we're not really sure ourselves. It's somewhat controversial, it's still evolving. Usually we use the term atypical mole to mean that it's clinically abnormal. So when we do the skin exam, we look at it with our eyes and with these tools, it looks funny. Dysplastic nevi usually refers to the funny looking mole as it appears under the microscope. So it's histologically abnormal. If it were so clean cut like this, it would be easy. But the problem is that there isn't much concordance, means that they don't match up that well. So not all of the clinically atypical moles, the ones that look funny to my eye, may not be funny looking under the microscope. And not all of the ones that were funny under the microscope might have been funny to my eye to begin with. We may have removed it for other reasons. Now, the NIH tried to come in with another definition to try to fix all of this, and they recommended a terminology for what's funny under the microscope, and that's nevus with architectural disorder. So, did that really help? So there was a survey that was recently done by a colleague of mine at University of Pennsylvania, and they did a random sample of close to 400 dermatologists. Some of them are also dermatopathologists, and some of them are practicing clinicians from members of the American Academy of Dermatology. And they asked them, okay, so if you had something that was microscopically dysplastic, how would you like to call them? What do you call them? And what they found was that there was a huge amount of variability. The first most common preference is to call it a dysplastic nevi, and they like to have the level of dysplasia graded into mild, moderate, or severe. The second most common was the NIH recommended term, but as it turns out, those people who had some dermatopathology training were the ones that most preferred that NIH term. Now here at Emory, we prefer the first. We like to call it a dysplastic nevi. We like our dysplastic nevi graded into mild, moderate, and severe. Now, what do we do with this? So those of you who are my patients have heard this before, we think of it as a spectrum. So on the one hand, you've got a totally normal mole. And then on the other hand, on the other side, you have a melanoma. And in between, you have mild, moderate, and severely dysplastic nevi. So the mildly dysplastic nevi are barely different than a normal mole. And even if it comes very close to the margin, we really don't do anything more with it. If you, on the other hand, have a severely dysplastic nevi, even though there's no guarantee that severely dysplastic nevi turn into melanoma, we treat it like a pre-melanoma. And so we will take a safety margin around it, especially if it's approaching the edge. Now, the moderately dysplastic nevi is sort of our gray area. So some people I will elect, this is a discussion with the patient, to watch it. Maybe this is their first dysplastic nevi. They don't have a family history. And so it might be worth it just to kind of watch it. It's an easy enough place, like on the arm, for them to watch it. On the flip side, we may have a patient with a moderately dysplastic nevi who's had a melanoma, who's had 4 or 5 severely dysplastic nevi. And so that might be a time to just go ahead and excise it because this person is probably at higher risk. Now, what's good to know is that there actually have been some studies done that have shown that the minimal and the moderately dysplastic nevi very, very rarely reoccur. Not even turn into melanoma, that they themselves rarely reoccur. Now, again, back to that same survey. So, what do your dermatologists do? So again, that broad survey show that when they were asked, what do you think the probability is that a dysplastic nevi would turn into a melanoma as compared to a totally normal mole, 27% that felt that all dysplastic nevi, whether it's mild or severe, are higher probability of developing into melanoma. And that might explain why some of you who've seen dermatologists have had minimally dysplastic nevi re-excised, because a quarter of dermatologists feel that even minimally dysplastic nevi have a higher chance of turning into melanoma. 60% felt that only nevi with the higher levels of dysplasia would turn into melanoma. And that's more in keeping of our philosophy here at Emory, in that we would go back and treat the more severely dysplastic nevi. And 13% don't feel that dysplastic nevi are at any higher risk than normal moles in turning into melanoma. And so you can see there's a lot of gray area here, even amongst dermatologists. Now, in your pathology report, you will sometimes see this term approaching the edge. And so what does that mean? And that's something that I often have to explain. So this cartoon shows you what the dermatopathologist might see. So they see a melanoma, but it was cut out. And so those dotted lines represent the edges of what they're able to see. And so they clearly don't see a rim of normal tissue, so it approaches the edge. Now, they can't comment because they can't see what's beyond those dotted lines there. It could be that there really barely is anymore, maybe a few more cells. Or it could be that there really is a long tail there. But since they couldn't see it, they really couldn't comment on it. And so they may recommend, depending on how severe the dysplasia was, how atypical it looked under the microscope, they may recommend what they call conservative re-excision, meaning why don't you take a little bit more just so that we can be sure that it's all out. Now, what Dr. Washington and I do sometimes is, okay, we don't want to have you to come back again. So what we will do is to go ahead and not only remove the mole, but take it just a little bit more, especially if it's not in a real cosmetically sensitive area like on your face or something. If it's in the middle of your back, why don't we just take a millimeter more? You're probably not going to miss it. You're probably going to thank us for not having to come back again to do just a tiny bit more. And so that might be a conversation that you might want to have with your dermatologist, is just to take a little bit more during the biopsy if it's at all possible. Now, we've touched on this a little bit before, but just to emphasize that not all dysplastic nevi are created equal, you have to put it into context here. There's the sporadic versus the familial. There's also a terminology called FAM, which is the familial atypical mole and melanoma syndrome, and that's if you have more than one family member, either a first or second degree family member with a melanoma, you yourself have more than 50 moles or melanocytic nevi, some of which are clinically atypical, and many of them under biopsy have shown dysplasia. And some studies have indicated that the lifetime risk for these patients that fit the FAM syndrome will guaranteed develop a melanoma. The sporadic atypical moles, we have some epidemiological statistics. Some studies have reported up to 17% of Caucasians have at least one sporadic atypical mole. Any given individual, nevus turning into melanoma, atypical nevus is 1 in 200,000. For U.S. Caucasian population, the melanoma lifetime risk is 1 in 150. Now, the challenging part of this is about 51% of adults will report that there's some evidence of change in their mole. And this is what's really hard, because not all change represents melanoma, but we're asking you to look for change. And so what do we do with that information? So here's the big picture. Lots of controversy, lots of opinion, very gray. The stakes are high, though. We don't want you guys to develop melanoma. So we need to concentrate on early detection, especially if you have a lot of moles. So how do we do that? Well, like Carl alluded to, it's good to have a good set of eyes, but sometimes we need a little bit of help. And so what I'm going to talk about is total body digital photography, a little bit about dermoscopy, introduce you to what's on the horizon in terms of evolving technology, and then again I'll conclude with some genetic testing. So Carl showed this slide. It's a very favorite slide of ours because how in the world am I supposed to remember all these moles? I mean, this person themselves has a hard time remembering all their moles. I see them maybe 2-3 times a year. I am not going to remember all their moles. And so what we used to do was something like this, which was practically useless. But luckily, you know, we have photography, we have digital photography, and now we have even better technology. So what this total body digital photography is all about is that we take some baseline pictures. So top to bottom, standardized lighting, standardized poses. In the past, we did a homegrown type of thing. Pictures weren't that well captured. But now we have these baseline pictures to which, when you come in for another exam, we then can compare to those pictures. If there's change, then we want to catch it as early as possible. If there is no change at all, no matter how funny looking that mole was to begin with, that mole's being quiet. So there's no need to do anything about it. It may remain quiet for the rest of your life, and so then we would save on an unnecessary biopsy. Now the nice thing about the new technologies is that we have this zoom in capability. I'll show you a picture of that, where we can actually look at one particular mole with high level of detail. And what we can do then is also to have you come in, you know, visit after visit, and then we'd be able to figure out what's new and what's changing. Now there are 2 different companies that provide mole mapping. One's Digital Derm, and the other one is Canfield. We use Digital Derm here at Emory. There is a certified medical photographer who takes your picture. You get 33 images standard, and then it's burnt onto a CD, and a copy is given to you to take home so that when you do your skin exam, you can pull it out and use it. The other one is given to us so that we can keep it, so when you come in for your exam, we can use it alongside. We have this computer that we roll in, and we can use it. The other company is actually more established. The advantages to the other company is that they can attach on other types of images that I'll show you, and that it doesn't require a medical photographer necessarily. It could be the physician who takes the picture, but as Carl and I can tell you, we'd rather not take the pictures, we'd rather have the photographer do it. And they also will produce a photo book, a very fancy, extremely beautiful, high-class book of naked pictures of you with all these moles on it that we can use. And we've inherited patients who've brought the photo book, and they're just as good as the CDs. So anyway, this is a picture of what it would look like. This is the Digital Derm, the front thing. We click on this View Confidential Patient Images, so it's not like your pictures are up, you know, in the room without us having something way to hide it. Once you're ready to use them, then these 33 images come up. And then what happens is that we will click on the body part that we are interested in observing, and then we can pull up each picture and then identify a particular mole, which we can zoom in at very high quality so that we can see, was that little dot there before? And if it was, then we feel better about it, okay? And it's nice to have this picture, because if I only saw this picture here, which is what happened in our old photos, where anatomically were these 2 moles? Like, we don't know which part of the body it was, and that was just such a nightmare. But with this technology, we actually can get through the exam pretty confidently. Now, why is it that not all dermatologists do this? Well, I'll tell you, it's very time consuming. It's very tedious. So not everybody wants to have that in their practice. It's also very subjective, and it requires a lot of individual physician experience and style. Wouldn't it be nice if we could get a computer to take a look at all these pictures and figure out which ones have changed? And so that's really what's on the horizon. So side-by-side comparisons so that you can have 2 sets of pictures of the same person, take a look and overlap them to see whether or not anything has changed or not. Well, if you look at me now, I'm standing right in front of you facing on. Now, if I turn a little bit, I look different, don't I? It's still me. But that's the problem with the photographs. If you turn even just a little bit, the mole looks different. And so that's been the problem with this particular technology. Now, luckily, the Missile Defense System is interested in healthcare. And so Raytheon has partnered with a colleague of mine in Arizona to try to use some of this, I guess these clone drone things that bomb and be able to identify civilians versus, you know, people that need a bomb. Anyway, they have these they have these really fancy algorithms that they are now translating into detecting moles, being able to put things side by side, accounting maybe for that little bit of turn, so that we can then utilize these fancy computers to help us with detecting change. Now, one thing that we do use in our clinic is dermoscopy. And so this is a tool, you may have seen your dermatologist pull this out. We have this pocket version now that's based on polarized light. We have this, what I call the old Buick, but I still use it, version, which uses oil. So the dermatologist will put a drop of oil on the particular mole and actually put the instrument on you. What it allows us to do is to take a look through the skin, through the epidermis, into the upper parts of the dermis, and we can see certain patterns. And these patterns tell us whether or not it's a melanoma. So for instance here, this pattern here has this blue-gray veil and these little feet that come out to the side. These are sort of things that we teach our residents to learn to recognize, to know that this is something suspicious for a melanoma, as compared to something like this, where we don't see all those fancy features and it looks very symmetric and very bland, what we call a lattice work, and this is a totally benign mole. Now, okay, I need some help. I probably have to click here. Okay. Now the problem with, so the nice thing about dermoscopy is that it can increase the diagnostic sensitivity. Some studies have shown that it can increase it up to 27%. But it is designed for thin melanomas. And the other little wrinkle in all of this is that there's a huge learning curve to using dermoscopy. In fact, there's studies that have shown that dermatologists who are new to dermoscopy do worse in making a diagnosis than if they had not relied on dermoscopy. So, so that's something to keep in mind. Now, on the horizon, again, you can see that that's, again, another picture and something that we have to learn, something somewhat subjective. So can we use computers to come in and take a look and figure out what features should be worrisome or not? Well, unfortunately, despite all the work that's been done, none still has been shown to be superior than the physician actually coming in with a dermatoscope. And part of the problem is that these computers have to be taught based on the pictures that you feed it, and maybe some of the problem is that it's been fed too many melanoma pictures and not enough benign pictures, because some of these algorithms have been classifying these benign things called seborrheic keratoses as melanoma, and so definitely more work has to be done on that. There is another technology that's on the horizon here that will take these pictures, give it a score, and then compare it to the score that was given to the same lesion previously. And so if the score seems like it's getting worse, then it'll recommend a biopsy. Now, one thing that's kind of exciting is this multispectral digital dermoscopy image analysis, and this is based on the fact that different wavelengths of light penetrate the skin deeper. And so if you can penetrate deeper and deeper, you might be able to take pictures deeper and deeper into the skin, and that's exactly what this technology does. So kind of like a CT scan that sections it into multiple sections and gets information from each section. And so then what it does is it compares it again to this big computer brain of theirs that's been fed all of these photos of these sections of known melanomas and benign lesions. And then this technology will then classify it into biopsy versus no biopsy. And the nice thing about this is that it's probing up to 2 millimeters below the surface of the skin. something that our naked eye can't do. And this is this technology has been developed by a company, the Melasciences company that I told you about. It's called Melafine. It looks like a big hairdryer. And the physician needs to put this device on the mole that they're worried about, and then the computer will do what it's supposed to do. Now, I know this is a lot of numbers here, but what I want to point out to you, this is some preliminary data that we've gotten. This MSCVS is the Melafine technology. The sensitivity, so the ability to pick up the melanoma, is extremely high. It's 97%. Compared to the physicians in that top row, whether they're pigmented lesion experts, that's what PLE, general dermatologist, or primary care physician, the PCP, it is much higher. The physicians are doing it in the 70s range, whereas the Melafine is in the high 90s. Now, the sacrifice that you make is in the specificity. So Melafine is actually telling the physician to biopsy even benign lesions. And so you really do sacrifice in getting unnecessary biopsies. If you compare to the highest, most sensitive, in terms of the diagnostic accuracy, not their emotions, physicians, on average, it matches the Melafine. But if you look at the specificity again, these particular dermatologists are biopsying many benign lesions in order to get their sensitivities that high. So I do feel that Melafine does have a role. It will detect many melanomas. What we just need to decide, is it worth the cost of biopsying many non-melanomas? We still, this is not a whole body thing. We still need to be able to pick which lesion to put this device onto. And there's a question that's circulating whether or not this device is actually better for non-dermatologists as compared to dermatologists. Again, on the horizon, there's a technology being developed. It's a video camera with a head for that dermoscopy, and it'll compare digital images across time. And this particular technology seems to have very good sensitivity as well as specificity, but not quite ready for a prime time yet. There are many other diagnostic tools that I can go into, but these are either not ready for prime time, or they're way too expensive for even a place like Emory to afford. And hasn't had the track record yet that we'd like for it to eventually obtain. Now, I want to conclude about the genetic testing. So this has become quite hot news. It's called the CDKN2A. It is a mutation in a gene that codes for a protein that stabilizes the tumor suppressor genes, P53, as you've heard earlier this morning. So if it becomes mutated, then things get out of control, and then people develop melanoma. Now, the interesting thing about this is this particular mutation is associated with also pancreatic cancer. And so the reason why this is of particular importance is we're not going to follow you any more carefully with your skin. We're doing everything that we can. But pancreatic cancer is usually not detected until it's too late. So I'm sure you've heard the celebrity news, Patrick Swayze, Michael Landon, our Supreme Court Justice, Ruth Bader, anyway, luckily hers was detected quite early, but everybody else's was detected fairly late, and you don't get symptoms until you're very late. And so that's why this is actually important. So who should get this genetic testing? Well, this is quite controversial, but there is sort of a guideline out there about the rule of threes. So any one person who's had 3 melanomas, or if you've had a melanoma and 2 close relatives with melanoma, or if you have 2 melanomas and you've had a family history of pancreatic cancer, these are people that we would start talking to about maybe getting genetic testing. Now, the opponents, or the people who are a little more wary about doing the genetic testing, have a valid point. The top-of-the-line screening is not standard of care. So the place that really promotes and developed this genetic testing has 3 different ways that they would test you for pancreatic cancer if you were to test positive with this CDKN2A. One's a routine blood test, we do that here too. One is with ultrasound, we do that here too. But then they also do a videoscopic endoscopy where they feed a camera down your esophagus and start taking a look at your pancreas, and that's not routine. That's not considered standard of care. That's not offered everywhere. And so if you can't offer that, should you be giving somebody this test? The other thing that you should know is that the CDKN2A is not comprehensive. It's just one mutation. There are many mutations that can happen even with this melanoma pancreatic cancer syndrome. So having a negative test doesn't give you this, phew, I don't have to worry about this anymore. It doesn't. And so is it worth doing this testing, especially because it's not cheap? But if you're interested, we do offer it here at Emory. It is approximately $400. I just found out from one of my patients that her insurance did cover it. But remember, a negative test doesn't mean that you don't have this genetic type. It just means that you were negative for that one test. So the cure for melanoma is still elusive. Luckily, if you catch it early, survival is very good. And so early detection is really still the best approach in terms of dealing with melanoma, and that's why I've presented all this information to you. And I just want to acknowledge a former fellow of mine, Dr. King, and my colleague, Dr. Clara Curiel, who helped me a lot putting these slides together. Thank you.